And yeah, to bring some insights or some topics related to what we've been working at Philips most recently. As you may know, and I've been working for a division of Philips, of a software division. We have software products in the market, so we do have a product in the LATAM market, an electronic medical records. And my idea here is to give an overview of some aspects related to AI and some use cases, and then at the end I will present some artifacts, video, a demo, a short demo of what we are doing now, maybe, and hopefully we have time to change some experiences and for a Q&A.
Bueno.
So may I share my screen?
Ahí estás compartiendo.
It should be now.
Sí, o sea, se ve que estás por compartir algo, pero todavía no se... Ahí está. Ahí veo. Ahí se ve tu pantalla.
Yes. Okay. So yeah, the idea, aligned with the mission of Philips, our idea is to improve people's health and well-being through meaningful innovation. As I mentioned, we have products in the market to try to address those challenges. And specifically for this talk, I will talk a bit about how we are using AI, in special Gen AI, to support and to revamp human-human interactions in healthcare. Yeah, briefly on the agenda, some highlights on the challenges that we are facing in the healthcare ecosystem. Bring some discussion on the quintuple aim framework and are we improving staff experience indeed at this point in time. And then I'll talk a bit generically about Gen AI in healthcare with some literature overview. And at the end, I'll give a short demo session of our solutions, our vision and our solutions, and then let some time for us to interactions. Yeah, so we all know that the complexity of the healthcare context. There have been some frameworks putting in place to try to support us to address this complexity. I like very much this image here because it encompasses lots of different aspects of the healthcare context, where the care should be delivered, what are the stakeholders involved on these interactions. What are the data points, how they interact with payers, providers, and yeah, healthcare professionals being exposed to situations in which they have to manage efficiency while giving at what they are more used to do, that is take care of their patients. And yeah, and again, this is not to be read, but the complexity, and this came out from some reflections that I have. So I'm listed here some of the challenges that we've been facing. Some of them are technological, some of them are processual, some of them are personal. But again, there are a lot of things happening, and we as healthcare professionals or care providers, now mentioning the guys that are at the bedside, we have to tackle and to handle some of those challenges even in our daily basis. A couple of years ago, there were some systems or a promise that some systems or the technology could support us. And I liked very much this prevision, I would say, out 2007 for Gartner, mentioning that the health systems, in special EMR systems, there will be those 5 generations of products that will start collecting data, and after starting supporting on the documentation, helping, supporting as a colleague, and theoretically or ideally even support us in mentoring the healthcare professionals. As you can see here, the provisions were for that to be in place in 2015 onwards. unfortunately, in my perspective, I think that we are not there yet. So the vast majority of our systems, they are typically collectors, documenters. We can, in some extent, expect some help, but colleagues and mentors, I think that we are not there yet, despite of the provisions that we had in the past. And just to mention here, just to give some context, as you may know, so there are some frameworks trying to understand those complexities on healthcare, health delivery, and trying to bring or equalize or trying to balance the different strengths or forces that are involved on healthcare delivery. And when we look to this quintuple aim framework out from AIHI organization that states those 5 pillars here. So in order to achieve those quintuple aim, in order to give the sustainability to the segment and the better care, you have to ensure that you are bringing equity to the system. This is the quintuple aim, just recently added to the model. And as you can see, other pillars are related to patient experience, better health outcomes, reduction, lower cost of care, or avoiding waste of money. But I would like to focus specifically in one of those pillars, that is the staff experience. So as technology providers, and we can understand, we can realize that this is one of the aspects that we may impact more with our solutions. And as you may know, doctors, why doctors hate their computers. This is an interesting publication a couple of years ago. You can see here one doctor in the first plan and her patient underneath behind a lot of screens. So this is an interesting discussion that took place in the past and is still running. I decided to bring some evidences or texts that are on this domain classical. So this is one of the examples. So there was this study not that new, but talks about health time of allocation of healthcare professionals in an ED in US. And what I like on these studies is that you can see that the time on this study, the time that was used during the clinical shifts to take care of patients or in patient context was less than 1/3 of the time. And you can see that almost 44% of the time of the healthcare professionals on that study was to document their interactions, data entry. This study was known as the 4,000 clicks study. So that was the number of clicks in average that one healthcare professional in that institution gave by shift of 12 hours. So can you imagine? And if you use a number of clicks as a surrogate of complexity or lack of usability of a system, you can imagine how much those professionals are under pressure. So they have to expend more time or dedicate more time to administrative perceived as low quality or low value task delivery rather than taking contact with their patients. It's well known also the association between usability of electronic health records and burnout. Another classic example, publication that displays here the usability scores of EHRs. So you can see here the comparison of using usability scales like SUS. And you see that the EHRs, they grade F, so unacceptable user interface or usability of those systems, but worse than Excel and if you compare things like Google search, microwaves as good examples of things that are usability, in which the usability is quite good. EHRs the grades are very low. And on the same study, it was assessed and based on the satisfaction or the SUS score and some symptoms related to burnout syndrome. You can see that on top of the lack of usability or the low grade to the systems, and on top of that, clinicians or professionals that are less, or they are less used, or real, or perceive the system as less useful, they have a greater choice or greater chance to experience burnout symptoms. Yeah, this is a study with physicians, but we have also publications with nurses before and after COVID. So the association between burnout, critical care, and electronic and technology, in special electronic health record, unfortunately, it's quite nicely documented in the literature. And then we face this new era where those AI took place. So it's now here. And when we talk about generative AI or foundation models, it's clear that there's this potential to transform healthcare. I like very much this recent publication of Nature highlighting potential framework that we can rely on to implement technologies or AI technologies to support adoption in one hand. And so based on a literature review, of course, not extensive, there are some archetypical use cases in GenAI that have been explored worldwide. I have to mention that for our scope, in healthcare, typically summarization, data extraction, generation of content has been the ones that are most evaluated at this point in time. And I will present something that we are doing on that regard. And when we look to clinical or literature evidence, we start seeing promising results in some aspects. So in this publication, you can see that large language models performing quite nicely. In fact, outperforming clinical experts in some administrative tasks like text summarization. So in this example, you can see that there was a comparison, double-blinded comparison of reports created either by experienced clinicians or large language models. And then those summaries, they were offered to clinicians, and they grade this blindly. They grade the level of completeness, correctness, and conciseness of these documents. And as you can see here, the results clearly goes through the side of the LLM. So the LLMs, the things that are more to the tone of blue, they favors the LLMs in spite of the red ones that favors the clinicians. In different aspects, you see radiology reports, patient questions, progress notes. And interestingly, also there's another assessment there. When you look to the patient safety aspect of it, we know that one potential risk related to this summary generation out from LLMs could be on the hallucinations or creation of information that is not to be there. And when you look to this, and of course this could happen also with human-created documents or hallucinations or lack of information there. So when you look to the patient safety aspects, potential patient safety aspects of the documents, you see here the opposite. So the documents created by real people, clinicians, they are most likely associated with bad outcomes of potential safety aspects. So this is quite interesting in one hand. But on the other hand, when you go through other use cases, so for instance here, diagnostic suggestion or clinical decision support, and you can see that another publication also from Nature Medicine showcasing that the results are not good. So clinicians still, specifically on this publication, clinicians systematically are better than machines when we are leveraging on complex information. So this research undergone under real life cases that were complex, a bunch of information that you have to integrate from a chronological aspect. So you have to go on lab reports and different sources of information to get that. And clinicians are still better than LLMs on this specific task. So this brings us to the creation of some frameworks to how to understand and to try to find the best opportunities or an LLM opportunity model. There are some models here and there, frameworks suggesting that. I like this one, for instance. So when you can, with this approach, when you compare how often the task is performed, and is accuracy important? When we are trying to address your needs and solve problems that are not important, even though they are performed frequently, rely on LLMs. Quality is not that a real problem. If there are some tasks that are critical and they're happening all the time, yes, use LLMs to support you. But at the end, the centauros, you have to have machine and humans interacting to get more best decisions. But there will be some specific tasks that will be always better to keep only for clinicians. So if you have that to perform that only once, and it's very critical, so rely only on humans. And this brings me to we are driving towards the end of the session. So let me show you some of the things that I'd like to share here. I will. Let me see how can I do that. Yeah, I would change the sharing. Let me see.
¿Es un video, Vladimir?
No, there's a video and there's a clickable Figma.
Okay.
Yeah. I need to know. Let me just check. I think that is the right one. You should be able to see one screen. Yeah. Please, can you give me some feedback here, Maria? Yeah.
Sí, ahí estamos viendo.
It's a mock. Yeah, this is a mock of mock-up of our product. So this is a clickable version of Figma file. So I will showcase one end-to-end scenario where I will get from out of a conversation of a patient the ability to capture the content of that conversation. So let's go there. So I will start and it's in Portuguese. Sorry for that.
Okay.
So I'm just.
Se entiende perfecto. Se entiende.
Yeah. So I'm now simulating collection of the consent from the patient. So then let's assume that we are under a consultation, for instance, and then I just collected the consent of the patient. So I say that here the consent was done. And then we can start the transcription of the conversation. Yeah. And then the conversation takes place, between clinician and his or her patient. This is a mock. We are now working and with some partners in Brazil, some customers to fine tune and to check the accuracy of those of the transcription. There are some clear feedbacks here and there. How can we handle that? Should we handle that in real time, as I'm showing here? That is not necessarily the case. But let's assume that the conversation is taking place. So I'm capturing this information. That at the end will generate a transcript. So that conversation that could take 10, 15 minutes, half an hour, will generate a content that will be transcribed as a conversation that is understandable, but the information is hidden there. So this is not the way that typically we record information in our systems. But I can ask using LLMs, give the prompt and some context to out from that transcript to generate a clinical note, based on that content. And then when I have a clinical note based on the template that I want to, this information will be displayed in a way that, based on the format that we would like to. So in this example here, it's an unstructured text. in which you can see information described in a narrative way. And again, triggering LLM processes, and I can, based on different template, put an agent there to look at that content and try to find out clinical relevant concepts from that transcript, identifying them and assigning to the specific entities. So, for instance, in this example, I could find those diagnoses, allergies, medications and use, and things like that. There are codification aspects underneath this, but at the end, I'm able to, from a non-structured clinical note, be able to extract information, and this information will be afterwards structured and enter in the system. So out from an ordinary clinical note. Let me stop sharing and getting back to my main screen. I would like, the video would showcase almost the same thing. I think that I would like to maybe have some couple of minutes just for a final discussion. I will move onwards and bring back to the complexity. So what we are trying to solve now is bringing that complexity that we've been discussing so far in a way that you can organize information, provide value to the stakeholders via efficiency, satisfaction, and increasing access. Why? How can we do that? Connecting the dots, because at the end, what really matters, what we as healthcare professionals, what we really want is interact with people. Of course, technology should be there, should collaborate with us, but should be an enabler, not a distractor. Yeah. And with this, I'm finishing my talk.